Assalamualaikum doctors. In this video I am discussing the management portion, history, Addison's disease. So Addison's disease, we know, an ability to produce the hormones. How can I manage? First of all, I will examine her carefully, vitals, blood pressure and glucose. I will assess the airway, breathing, circulation and consciousness level, Glasgow Coma scale. Obtain IV line. If in shock, shock therapy. If in pain, analgesic. I will discuss with the consultant if she needs admission. Anthropometric measurement, plot on growth chart and check his previous measurements. I will involve my senior and if needed my consultant, I will run some test. So again, first what we do, Addison's disease, I will examine her carefully. Vitals, blood pressure, glucose. I will assess airway, breathing, circulation, consciousness level, Glasgow Coma scale. Obtain IV line. If in shock, shock therapy. If in pain, analgesics. I will discuss with consultant if she needs admission. Anthropometric measurement, plot on growth chart and check his previous measurements. I will involve my senior and if needed my consultant, I will run some tests. Then I will do the investigations. So investigation, first of all, full blood count. Anemia, we can find urea and electrolyte. They have low sodium, hyponatremia and bicarbonate, high potassium and calcium, glucose low. 24-hour cortisol in urine or early morning cortisol in blood. ACTH level elevated. Plasma renin is high, aldosterone level is low. Antibodies against 21 hydroxylase positive in autoimmune Addison's, either isolated or as part of polyendocrinopathy. If male with neurological and behavioral issues, VLCFA will be high. Adrenal leukodystrophy, X-linked recessive. Diagnostic test is that short synecthin test, injection of ACTH, then measure cortisol level in blood before and after 30 minutes and after 60 minutes. Normally increase cortisol productions. If low cortisol, so Addison. Long synecthin test, IM injection of ACTH daily for 3 days to differentiate between the primary and secondary adrenal insufficiency. If primary adrenal causes that high ACTH and low cortisol, if secondary pituitary causes low ACTH and cortisol levels. Note, pseudohypoaldosteronism is due to unresponsive or resistance to aldosterone at its receptors. So high renin and aldosterone level and hypertension and hyperkalemia and hyponatremia. Other workup for other autoimmune disease. Radiology, we are doing abdominal CT and ultrasound scan for adrenal gland and X-ray, calcification if TB, MRI brain, chest X-ray or CT, ECG for the effect of hyperkalemia. Annual review, labor, full blood count, urea and electrolyte, liver function test, vitamin B12, parathyroid hormone level, celiac screening, thyroid functions, glucose and HbA1c. Review of the skin. If skin thinning and stria, steroid toxicity and search for hyperglycemia and hypertension. Steroid overdose. Then if pigmented skin, generalized fatigue and weakness, search for hypotension, low dose or poor compliance. So again, what are the investigation we do? For Addison's disease, full blood count we are doing, anemia and urea and electrolyte level, low sodium and bicarbonate, high potassium and calcium and glucose is low. 24 cortisol in urine and early morning cortisol in blood. ACTH level is elevated. Plasma renin is high, aldosterone level is low. Then antibodies against 21 hydroxylase. Diagnostic tests are short synecthin test and long synecthin test. Others are radiology, abdominal CT and ultrasound of the scan of adrenal gland and X-ray. MRI of brain, X-ray, chest X-ray or CT, ECG for the effect of hyperkalemia. Labor, full blood count, urea and electrolyte, liver function test, vitamin B12, parathyroid hormone level, celiac screen, thyroid functions, glucose and HbA1c. And if skin thinning and stria, that is steroid toxicity and search for hyperglycemia and hypertension, steroid overdose. If pigmented skin, generalized fatigue and weakness, search for hypotension, low dose or poor compliance. So these are we are searching what is the management of Addison's disease. Treatment of Addison's disease is that treatment of adrenal crisis, urgent treatment with IV normal saline, glucose and hydrocortisone. Long-term management with glucocorticoid and mineral corticoid replacement, parent-patient education. So urgent and long-term medication. Urgent treatment with IV saline, normal saline, glucose and hydrocortisone. Remember, urgent and IV normal saline, glucose and hydrocortisone. Long-term treatment is a steroid replacement with the mineralocorticoid and glucocorticoid. And parent and patient educations. Multidisciplinary team we are involving endocrinologist, dietitian, gastroenterologist, social worker and support to the family, psychological support and psychiatrist if needed, liaise with the school for emergencies and for bullying. So endocrinologist, dietitian, gastroenterologist, social worker and support to the family, psychological support and psychiatrist if needed, liaise with the school. Then advice bracelet, that medic alert bracelet or necklace. So bracelet use, steroid card use, education of the patient and family about the sick days rule, and when they must double the dose. Febrile illness, gastroenteritis, major trauma, surgery, endurance sport. Okay, so education about how to inject IM hydrocortisone in emergency, importance of treatment and good compliance and follow-up. So some advice like bracelet, steroid card, education about the Addison in crisis, emergency situations, how to give IM injections. These are educations. About education about the follow-up and the full disease. What is the adrenal crisis? Adrenal crisis symptoms are hypotension, hypoglycemia with fainting attack, vomiting, abdominal pain and low-grade fever. So hypotension, hypoglycemia with fainting attacks, vomiting, abdominal pain and low-grade fever. Treatment admission ABCD, IV hydrocortisone, IV fluid, fluorocortisone. Not in the first year, give salt instead and antibiotics if needed. Sick days rules. Sick days are mild, moderate and severe. If mild, double the dose of hydrocortisone for 24 to 48 hours. If moderate, double the dose, and if vomiting after 1 hour, start IM injections. If severe illness or collapse, IV hydrocortisone and call ambulance. So mild, double the dose, moderate are IM injections, and severe IV hydrocortisone. Okay, these are. So treatment, we understand the treatment of adrenal crisis is that treatment of adrenal crisis, urgent treatment is IV normal saline, glucose and hydrocortisones, and long-term management is that glucocorticoid and mineralocorticoid replacement, patient education, multidisciplinary team and some advice. So this is all about Addison's disease management. Thank you.